Good evening, everyone. Welcome to the first webinar for the WEO research webinar. It's my pleasure to welcome you all for this exciting initiative by the WEO. And this is the first of the series. We will be having two more to come the next couple of Wednesdays. So my name is Krish Ragunath. I'm Professor of Medicine at Curtin University and consultant gastroenterologist at Royal Perth Hospital here in Perth, Western Australia. It is my pleasure to welcome my co-panelists and the speaker today. The speaker today for us is Dr. Payal Saxena. Payal is Associate Professor of Medicine at the University of Sydney. She's a consultant gastroenterologist at Royal Prince Alfred Hospital in Sydney. Payal had trained in Sydney, and then she went up to the US at Johns Hopkins, where she did interventional endoscopy fellowship for 2 years, where she has done some exciting endoscopic work and also published quite extensively in the field of interventional endoscopy. So she is going to be with us today talking about how do I start research in endoscopy. The two panelists who we have today are Professor James Lau. James is chair in surgery at the Chinese University of Hong Kong. He is well known internationally for all his publications in the field of peptic ulcer disease and the seminal work what he did in the use of PPI in peptic ulcer disease. So James is going to be one of the panelists with us today. Thank you very much, James, for joining us. The other panelist is Professor Sanjiv Mahadeva from the University of Malaysia. Sanjiv is quite an experienced endoscopist, and he's also a chair of the national chair for the training for the GI trainees in Malaysia, and he has published quite extensively. He's the editorial board of several international journals and has a big portfolio of research in endoscopy. So Sanjiv will be our second panelist today, and I would like to welcome Sanjiv. Thank you very much. Without much ado, can I ask Payal to start the talk, please? Thank you very much, Payal.
Thank you very much, Krish. Thank you for the very kind invitation, and thank you to the WEO for this opportunity to speak this evening. So thank you for this very interesting topic, Krish. This is research in endoscopy is something that we often just have to figure out and learn on our own, and it's a great initiative to try to help guide some of our upcoming researchers on how to begin and how to move forward with research in endoscopy. So the positive thing about endoscopy is it's a technical discipline which is evolving, and it's evolving rapidly in the last few years, and therefore many research opportunities exist. In particular, we have research opportunities with regards to the procedures and techniques. And as we all know, with endoscopy, we do both diagnostic as well as therapeutic procedures. So there are opportunities to evaluate questions and research in areas of diagnostics as well as therapeutics. Also, being a technical specialty, there are a lot of new devices that are up and coming in endoscopy. And so we have opportunities to research and evaluate new devices to see if they improve outcomes for patients or improve some aspect of a procedure or a technique. And of course, when we do research, we should share this with our community. So it's really important that whenever we do research, we do try to convert all our work into a publication. So what is research? The definition is that this is a systematic investigation into and study of materials and sources in order to establish facts and reach new conclusions. Why should we do research? Well, the first most thing is that there may be very many unanswered questions in your practice and the type of work you do. For example, why do we have various types of needles in endoscopic ultrasound? And are they better than the other? Why do we have different sizes? Is one size better than the other? And over the many years, there's been lots of research into this question, and therefore we've been able to answer a smaller gauge or a larger gauge needle, and what type of needle tip is better for obtaining tissue diagnosis in patients with, for example, pancreatic cancer. The other reason we do research is to challenge the status quo. So, for example, previously it was It was standard for patients to go to surgery for big lesions in the colon, which people felt were not endoscopically removable, but this has now changed. Now we know that lots of research has shown that even for early cancers of for the esophagus and the upper gut, that endoscopic resection is as good, if not better, in terms of outcomes for patients as well as achieving cure. We also do research to investigate novel ideas. So think about third space endoscopy. It was just an idea in the lab in a pig study that maybe we could create a submucosal tunnel and access a new area of the GI tract that we previously didn't access. We only did luminal work. And now we do so much third space work, which has really changed the way we deal with a lot of conditions, in particular achalasia and also subepithelial tumors. And most importantly, when we do all this research, we publish our work, we share our knowledge with our colleagues, we are then able to create a platform for evidence-based medicine and practicing medicine, which leads to improved outcomes for the patients, as well as the techniques and the procedures that we do. And most importantly, research is not a fishing expedition. So you shouldn't think of research as, I have a whole bunch of data here on this particular type of procedure. Let me see what I can find. What can I try to show and then try to publish it as a study? That is not research. Research is when you come up with a hypothesis, a question, and you design a method for evaluating your hypothesis and answering that question. So there are a few key considerations for newcomers to endoscopic research. And the number one thing is think about your research question. So in reference to it's not a fishing expedition, think about the problem that you want to address, why it's a problem, how you're going to work out a solution to this problem. And that is your research question, and then you design your protocol around it. Engage a team. Research is not a single person show, it's a team effort. So you will need people to help you do data collection, you will need people to help you do statistical analysis. And most importantly, you should have a mentor, particularly when you're starting out something. You need a bit of guidance. You need to talk to people to help talk through your ideas. Are you on the right track? Are you wasting your time? So it's always good to have sometimes multiple mentors that you may be able to discuss different types of projects with. And very importantly, you need to be aware of the ethics or IRB submissions in your local institution. Everyone has different types of rules and different protocols. So it's very important that you look into that first and foremost, so that you're aware of what sort of an ethics submission is required for the type of project you are designing. And then once you've thought through those questions, put your protocol down on a piece of paper, write it out, read it to yourself, put it down for a few hours or maybe a couple of days and read it again. Critically analyze your design to see where there are problems and how you can redesign it. How would a reviewer think about this design? So you can try to optimize it, that you don't run into trouble later on when you're trying to publish your work and you're coming up across a lot of criticism. And so I think from that regard, it's really important to keep things simple. Try not to complicate things too much. Start with small, simple ideas and you can move forward from there. And when we do research, most people have an entire portfolio of research. You won't find academics who only have prospective randomized controlled trials and only publish meta-analysis and systematic reviews. We all have different types of publications in our portfolio. So start small when you're early on, when you're a junior resident or a registrar. Start with small things like case reports and case series. This gets you into the flow and the pattern of how to collect information, collect data, synthesize it in a organized fashion, and then putting down your ideas in an organized fashion when you write a paper, following patterns on how papers are written. You must read a lot of papers. So it's actually quite useful if you're in the middle of doing a randomized control trial on a particular topic. Go to the effort of maybe writing a review article in that topic. It's very useful for your own learning. You will understand more about that topic and more about what data you're collecting and what the possible implications are. And then, of course, when you write your discussion for your study outcomes, the more you read around your topic and other topics, the more you will learn and the better researcher you will be able to conduct. And similarly, when you get to a level when you do a lot of papers, write a lot of studies, you'll be invited to write editorials on other people's studies and journals. So this is the sort of portfolio you will eventually have. So literature review is probably the first thing and one of the most important things when you're starting out on a project. It helps you learn more about your topic, helps you prevent duplication of studies, not doing the same thing again and again. You may be able to improve on existing study designs that you've already read about, and you can learn from other people's mistakes. Maybe there have been some criticism on someone else's study, so you can modify the design of your own study to avoid those shortcomings and improve it. And you may come across some different ideas. While you're doing your literature review, you may come up with a new idea for a different type of a project that may be more interesting and more exciting for you. The next thing that's really important is to have a solid team. So like I said previously, research is not a single person job. In addition to your mentor or supervisor, think about collaborators. So you may meet people at meetings and conferences, which these days is online, but we will eventually return to meetings where you get to meet other people in similar fields in different countries, different hospitals, and you can collaborate with other people in terms of research. You may have an ethics or an IRB submission liaison person in your hospital or your institution that you can get assistance from. So for example, I have a scientist that I work with who does a lot of work with the ethics department in our hospital. So she helps us fine tune all our ethics submissions, which helps reduce and avoid rejections for simple errors, such as not having all your terminology correct on your documentation. So it's useful to have someone like that can help smooth over some of the processes. And engage your students, your medical students and your junior doctors. They may not be in a position to lead some big research projects, but they may have some time and may be interested in contributing to research, and they may be able to do some data collection and help contribute in that way. So engage a team that can help you with all sorts of aspects of your projects. And again, a biostatistician is very important. You must have someone look at the statistic analysis before you begin your project. So you need to have a hypothesis. You need to think about what is the outcome you're hoping for or you're predicting, and therefore you determine a sample size calculation that you need in terms of patient recruitment. And then after your patient recruitment, you will need to do data analysis to understand what you have learned from from your project. One of the other questions that often comes is, well, how do I fund myself and all my time to do this research? So there are different sorts of scenarios available. So some people do full-time research, some people do part-time research, some people do research just in their own time. So you may be in a self-funded situation where you find time on the weekends or after hours to do some research while you do your regular job. People have the opportunity to apply for government or university grants for research. A lot of industry will often sponsor research projects. So for example, if you're doing a project where you're investigating, the application of a particular device, perhaps the company that makes that device may be able to help sponsor some of your research. Of course, you need to be wary of bias in these sort of situations, but this is, again, another option to help fund some of your studies. Many medical associations and gastro and endoscopy societies also offer research grants. So you need to keep an eye out for these sort of options and plan ahead and apply as soon as you see any of these opportunities come up. Once you've done your research, it's really important to publish it. And one thing I learned from someone else is every paper has a home. So just because the first journal you submitted to rejects your paper doesn't mean it's not worthy of publication. Keep trying other papers, other journals. So some of the common endoscopy journals are listed here: GIE, endoscopy, digestive endoscopy, surgical endoscopy, gastroenterology papers, and the list truly just goes on and on and on. The nice thing about every time you submit your paper to a journal, you will get feedback from the reviewers, who will either give you positive feedback and also some criticism as to why they didn't think the paper was good enough to be published, or they will give you some suggestions on, can you please modify A, B, and C, and then we think it's fit for publication. So you learn a lot from the reviewers' comments as well when you submit your papers to a journal. So if you think about research and how applicable it is, if you think about, just the last 20, 30 years, a lot of intervention that we did surgically for patients with GI diseases is now done in an endoscopic fashion. And this is through all the research and the novelty and the thinking outside of the box that has happened in the last few decades with our senior colleagues and people who've come up with, you know, various inventions. And just for the people here in the audience today, I'm sure even in your careers thus far, you have seen some ideas which have led to life-changing outcomes for patients as a result of endoscopic research. So think of POEM. It started as an idea just in a pig lab. It has now become almost standard of care and certainly a preferred option for patients with achalasia. EMR and ESD of early GI cancers. These patients used to have surgical resection, gastrectomies, which now can easily be solved with EMR and ESD, and the patient retains their normal anatomy and has a much better post-procedural outcome. All the EUS guided intervention that we do, you've seen all these landmark studies come out in your careers where we no longer send these patients off for surgery. All their pancreatic fluid collections are drained endoscopically and managed endoscopically, even if there is large cavities with necrosis. Biliary drainage, patients no longer require PTCs and drains externally. This can all be done internally. And even now moving into the hepatology area, liver biopsies can safely be performed endoscopically, and it's a preferred option for patients because it's just pain-free. So you will find over your careers as a researcher, you will start small and you'll embark on medium-sized projects. You will eventually lead to multiple publications, and you may become a lead researcher, and you will have a research team working with you who will contribute to more and more research within your unit. So in summary, research is important. It provides a platform for evidence-based practice which improves outcomes for our patients. Keep it simple, start small. Make sure you engage a team and discuss your projects, particularly when you're early on in your career. Discuss with a mentor, find someone that you can work with that can give you guidance, and always, always make it an aim to publish your work and share it with your colleagues. Thank you for your attention, and I look forward to the discussion.
Thanks, Payal. That was an excellent run through and sort of almost like template for which people can follow, especially their trainees. So I'm going to just start a question with you before I go to the panelists. We all train as a gastroenterologist, but some of us self-select ourselves to do endoscopy, intrusion endoscopy, or hepatology and IBD. So do you think there are any particular traits who choose endoscopy?
Yeah, I think as endoscopists, we are surgeons in a physician's body. And, you know, you encounter some surgeons in your careers, as colleagues who are maybe physicians in a surgeon's body. So I think people who are good at problem solving and are drawn towards specialties where you get instant solutions to the problems that you encounter are probably more drawn to endoscopy. And also it's a tactile specialty, people who are, you know, very comfortable and interested in using their hands and being quick on their feet. When you're facing you know, patients who are bleeding or cholangitis and major issues, we require people who are happy to make quick decisions and act upon them and don't feel like they need to spend time thinking about it. So I think these are the sort of traits that people often carry that helps them be drawn towards an interventional specialty versus a more thought-provoking specialty.
Yeah, that's interesting. And as you said, quite often people who choose to do interventional endoscopy or people who like to do tactile things. When you do that, your day-to-day work is always busy when you're going to be doing endoscopy. Almost everyone thinks, oh gosh, I want to know how this works. You know, I want to do a piece of research. But juggling your time, your clinical time, and then your research time is really very difficult. As a clinical academic, as you know, when you look into researchers in the lab they have a lot of time in the hand because they don't run an endoscopy list or an operating theater, whatever it is. So it's not that easy. And how, as an endoscopist and researcher, how do you motivate yourself, and how you time allocation is very important, especially when you are a trainee, when you're trying to do these things. It's important to understand how much time you need to spend for this. You don't want to do slipshod work. So if you want to do a research, it has to be done in a systematic way, like how you nicely demonstrated in your slides. So how do you manage your time doing this?
Yeah, so I think the answer to that question is different if you're a trainee still in a program doing research versus if you're an established consultant and doing research. So I'll answer it from a trainee's perspective, and maybe I'll reflect on my own experience. I had protected research time in my schedule. So say I had a 5-day working week, 10 sessions a week. I did clinical work, meaning I was scoping patients 6 sessions, and I had 4 sessions where I dedicated that to research time. So I think when you have a structure like that, where you have time that you're going to dedicate to research, then that helps you make sure you utilize your time appropriately. And the other thing is having some checklists or checkpoints. So once a month, I was always in a research meeting with my mentor, the other fellows in the research team, our lab people. We did a lot of pig research with pig endoscopy. So once a month we had a meeting. So that way you're responsible. You have to answer to someone each month. So you keep track of your work that you're doing. So it gives you a bit of structure to keep going. And I think, when you're at the other end of the spectrum, you've got a full busy clinical load. You have to find time and make time. And this is where you rely on your juniors to step up and take a bit more responsibility. So again, I still host a research meeting once a month with my fellow and a couple of other colleagues, but I make my fellow do most of the work and lead the projects and do all the legwork, and I do more of a supervisory role now. So I don't have to put as much time as I needed to when I was a fellow, but of course, when it comes to reviewing papers, etc., I do this all in my own time. So I think that's a commitment that you have to do. When I wasn't so busy clinically, I still had time during the week, but now that I've been in practice for 7 years or so, then I don't have so much time. So you've got to create time in your personal time. And that's just a decision you need to make.
Yeah, that's interesting. So, so my sort of a take on this is that when you are a trainee or even a junior consultant and you want to do research, the important thing is to find some mentors and people who have been successful in doing endoscopy research, and then starting with some small projects with them, supervising, and then slowly building on that. Good, thank you. Let me turn on to James. James, you're a surgeon, and your perspective to endoscopy might be slightly different compared to a physician going in. But as Payal said, it's a physician or a surgeon, but at the end point comes into endoscopy, where both of us use our hands in doing various things using instrumentation. So can you share with us your experience as a surgeon, being an interventional endoscopist and an academic researcher? How do you manage these things, and how do you motivate yourself to do this?
Well, first of all, I didn't start my own research like in a program, in a busy academic unit. Being part of a program, and when you're a registrar, you're obligated to do research. But often we were started by our supervisors. They will provide you with a project for you to finish. So this is how I started. So I remember collecting biles and serum for endotoxins from patient with cholangitis, and that was a topic given to me. And then also my second paper was on, a series on endoscopic balloon dilation for pyloric stenosis. I just went on to collect data. So when I started, the ideas didn't actually originated from me. So, and just going back to your question on whether I had the time, but most of the research we actually incorporated into our daily work. Like, if you when we do ERCP, for instance, I collected bile and serum, and that was just added on to our usual work. So as much as we can, we at least in our institution, we sort of protocolize things. When we do randomized control studies, we protocolize, everyone follows. So there are ways that you can actually make life a little easier for everyone. and also make life easier for yourself. Why I did endoscopy? Because I guess I joined a unit very famous for pioneering endoscopic therapy. I chose it that way, and later on I found that endoscopic therapy actually improves outcomes. I remember early days we were operating on about 10% of patients bleeding, and now we hardly ever have to operate on them. So that's also an incentive or a drive for you to do endoscopic research, because that really helps our patients. I don't know if I've answered all your questions.
No, that's fine. That's good. It's nice to, we are sort of warming up for the questions come through. So I have a question here from Dr. Payal. What are the tips for good project preparing and how to prepare a good clinical question? Would you like to take this question?
Well, I think the talk was great. I think the key to successful publication is to identify the deficiency in the literature. So I guess you have to read very extensively. You question every single thing that you do. When you do rounds and you're prescribing something, and you question yourself whether this is going to change the patient's outcome. So these are this is critical because clinical research is about improving patients' outcome. So when I do rounds, everything I do, I question myself, and then I research literature. And if I see that's a deficiency, then there's a clinical question to be answered.
I think
so,
that's
I was credited to be kind of a father to PPI, but there were, before my publication, there were a lot of publications on PPI already. I just had an idea, then I never knew I would publish well, but then I had an idea that was a deficiency in the literature. So read well, read critically, and always question yourself whether you're doing the correct thing by the patients.
Good. Thanks, James. I think what is important here is questioning practices as well. So, for example, before the PPI days, we used to be using H2 antagonists, and there were certain procedures which we used to do, which we hardly do these days. So all these things are because questioning the dogma sometimes also is important, and why certain things are done in a certain way. If you try to look at the literature, there is no evidence at all. People keep doing it. So those are all the things which makes you think to design a study or ask a clinical question. So I think that's a very important thing to acknowledge when you are doing it. And it's important in everyday clinical practice to question yourself what you're doing and why you're doing it, and why can't you do it the other way. And also when there is a need for certain things, then the inventions and innovations happen. So if you look into, for example, if you look into the GI bleed, glue injection to the fundal varices, Nipso thought about it. These patients are dying, and we are not really doing much to them. And then thinking outside the box and coming up with some answers to it is something what we all should be thinking about. So we have one more question which has come through. Do we need to submit all RCT to be done to clinical trial surgery? I'm not sure what is the exact question. Done to clinical trial or registry, right? Okay. Do you want to answer that?
I do a lot of randomized control studies, but I don't necessarily think that we need to do randomized control studies because we need justification for randomized control studies, so to speak. So we need to collect data on prospective series, and we want to know a clinical outcome to certain questions. And when you do believe that there's a controversy, then there may be a room for randomized control studies. And some of the answers are actually very obvious, even without randomized control studies. So this is my take on the topic.
I think, James, what they're trying to ask is registering in national clinical registries, trial registries, is important because a lot of the journals will ask you if this has been registered. And that's a question. And I think it is a good practice if you are doing any clinical trials and RCTs to register them.
Okay.
And also you can go in to see who is doing what. If there is another study already, a similar trial, randomized trial, then you will think twice about repeating the same thing. So it is a good practice to do it, because quite a few journals will ask you whether you're registered for it. I hope I have answered the question to Dr. Ravindra Gade. Thank you. Okay, let us move on. Sanjiv, can I ask you a question about your practice of your trainees in your unit, and when do you start encouraging them to do research in your training program, and do you ask them to start off like with some small audits and then think about asking a research question? And what is the line between an audit and a research? Sometimes people get confused with what is audit and what is research.
Yeah, thank you, Krish. But before I answer that, can I just to comment, and I think a very important key aspect that Payal brought up in her talk is that I think none of us who have got involved in research did not have a mentor. And, you know, especially for endoscopy, I think if you're doing endoscopy research, if you don't work or work with rather the key person who's doing a lot of these sort of big trials or rather publishing work in endoscopy, it's very hard for you to start off yourself. So I firmly believe that, and from my own personal experience, if I hadn't worked with certain people, that interest in research, endoscopy particularly, would not have come on. And I just wanted to ask Payal, how do you find that mentor? When I was a trainee, I had some of my colleagues, which I thought were really brave. They used to come to conferences with their CVs, and find all these big names and say, hey, please beg for a job, or let me do some stint in your unit for a while. Because let's face it, if you are working in a small hospital somewhere without that mentor, it's going to be hard for you to start off to do research. Am I right?
Yeah, you're absolutely right. I think you can find a mentor in all walks of life, even in the small hospitals you work at. It might not be big studies that you do in a smaller unit. You might do some case series or case reports, and then when you meet other people and meet at conferences, etc., you may engage with other people. You may sit next to someone at dinner and you have a discussion and you find you have similar interests. And I think most commonly it's usually people that you work with in your own unit or in a network. And I think it's also important to find a mentor that's like-minded. So you work well together, you think similarly, so that you're more productive together. You have similar interests in the similar fields. That often helps. But it's also good to have diversity. So I actually, during my fellowship, I made a point of working with almost everyone in my unit and doing some projects, doing some papers. I might not have done, prospective or retrospective studies with everyone. With some people, I only did review articles, but you have something to learn from all sorts of mentors throughout your life. Krish, I consider you a mentor. We've done some work together. And so I think you can find mentors in different walks of life, in different types of work that you do as well. So I think you just got to keep your eyes and mind open when you meet people as to the role they may play with you.
Thanks, Payal. Sorry, Krishna, I'll answer your question now. So for trainees, audits versus research, well, I guess audit, we would go towards audits if it was a question of improving quality in clinical service. And usually for an audit, you'd have some sort of gold standard to compare our standard of work. But you're right. I mean, many people would get confused between what an audit is and clinical research. And many people do wrongly label their projects as research when it's basically an audit. But I think audits have got a place, especially for improving quality in clinical service. I don't stress that as much. If I'm interested in getting trainees here to get into research, I like to start the traditional way of starting with case reports and case series, and then building up from then on to proper research projects. We have a regular weekly journal club, which I strongly believe is extremely important. So, and I'm sure most of us believe in that as well, because conferences, international conferences in our part of the world is not so easy to attend. Financial barrier being one of the issues. So we do have national meetings, of course, and most of our trainees will attend that, but not all trainees get to attend international meetings. So to get ideas for research projects may not be so available if people can't attend conferences. But if you have a journal club where the latest publications or interesting topics are discussed and presented by a fellow, that's a great way to stimulate thinking about research projects. I hope I've answered your question.
Yeah, thank you. Thanks. The reason why I ask this is quite often as junior trainees, you do an audit and then the audit ends up with some results, which in itself will give you a good research question to move forward. So that's sometimes you can use it as a step, and that gives you for the trainees, that will give them an experience on data collection and data analysis. So these are small things which will help moving forward, and then it'll come up with some conclusions. We'll give you some research questions. So I think that's something good for the trainees to start off small, doing some audit projects, like for example, any of the quality improvements. That will give them some of the results which can lead on to some good research questions, and that itself will give them experience on data collection. So we have another couple of questions which has come through. One question is, how to, when you are living in a place where you don't have any big academic unit and not many mentors around, how do you collaborate with the people abroad, and how would you sell yourself to them, saying that you may want to collaborate with them or you work with them? So this is one question which has come through. And perhaps I can ask this, Payal, do you want to take this question?
Sure, yeah, that's a challenging one. I think if you're
given the fact that, Payal, this is, people are logging in from different parts of the world.
Yeah,
and access to mentors, access to academic institutions, not everyone is in Hong Kong or Sydney or in New York. So when you are in a situation like that and you want to do, how would you go about with it?
Yeah, I think when you're in that kind of environment, you can tap into some other sorts of research or other sorts of resources. So, for example, the WEO group, offers avenues to connect with people in different parts of the world. With this whole COVID situation, everything's converted to online. So there's a lot of organizations and groups that are doing online webinars, and I think you've got the opportunity to meet people at these webinars. There's always the Q&A session, and people will happily, share email addresses, etc., to contact and communicate each other later on. Certainly, internationally, from a women in endoscopy perspective, I know there's a lot of WhatsApp chat groups now, and we have that opportunity to collaborate together for projects and papers, etc. So I think tapping into these other unconventional resources is also quite useful these days.
I think in one way, COVID has done some favor to us in the sense people are starting to connect using the internet. And now there are lots of meetings and webinars and conferences happening where you can virtually meet with people. So I would suggest to Dr. Paulak, I think, who was asked this question, to participate online in the big meetings like UGW or DDW, where you can chat to the speaker, or you can have a chat with the presenter, and then you can start networking, and then you can start doing research, because you can participate, even if you participate in an online, say, questionnaire survey or a Delphi process, and so on. Still, these are all research projects which will work out, and you'll be able to publish. Not necessary that you need to physically take a polyp out and publish and do that. There are other ways of publishing, and things like doing systematic review and meta-analysis. These sort of things you can do this online. There are online teaching courses and so on, which you can do yourself. So I think with the platform, what we have in the modern days with the internet, it's quite a powerful tool for us to do it. Yeah, good. Thank you. Thanks, Payal. Another question which has come through. This is a very interesting question, and personally, I myself have asked myself this question. As a trainee, we all do a piece of work and then excited if it gets accepted to. I still remember my first oral presentation in the British Society of Gastroenterology annual meeting, and I just couldn't believe that I need to be standing in front of about 500 or 600 people and giving a talk. But after that, converting that abstract or that presentation into a full publication becomes a challenge. And this is something which many people fall off the way. And if you look at someone's CV, you will see that they've got about 30 or 40 abstracts, but how many publications? Maybe 1 or 2. So James, what is your tips and tricks for to converting?
Well, I don't submit abstracts unless I have completed my work. So I try my best to finish a study. When I do submit an abstract, it's really for gathering criticisms or comments on my work. So I'm most of the time I'm ready to publish a full paper, and then I submit an abstract just to gather some additional insights. So this is how I do things. But I can understand why people's somehow their abstracts do not get into full publications. I think most of the time, I think the work is not ready, or when they submit and they find flaws or problems with the piece of work, and that's how I look at it. The abstract isn't quite ready as a full paper. So to me, I think you just have to persevere with it and just carry on with the work and complete it as much as you can, and write it up as a paper. So
thanks, James. I think that's a very valid point. To answer this question to Nitin Jagtap, personally, what I tend to do is like what James said. I would aim to do a piece of research and write it. So the abstract is, by the way, I got this abstract and I'll send it to one of the meetings, because if you submit an abstract to, say, DW within the ASGE, then you can write to the editor saying that this piece of work was accepted as an oral presentation for the ASGE. And now we are submitting this as a full paper. I would be grateful if you could consider this for publication. So this is a nice way of saying that, look, we have done this piece of work, we have presented in your annual conference, and we would like to submit it to the GIE journal as a full publication. Then that also carries a little bit of a weight when it goes for publication. So when you're starting it, don't keep your target as an abstract. Keep your target as a full publication. So abstract is, by the way, you present it, and as James said, you get some criticisms that helps you to fine tune your paper, and then you submit the paper. So I think that's the way to go about it. Any comments on that, Sanjiv and Payal?
Yeah, I was just going to say that I think a lot depends on the supervisor here. I mean, if you don't have a good supervisor, they're not going to push you beyond that abstract sometimes at a conference meeting. And I think a lot of it depends on that. Because, I mean, if you, truth be told, many fellows will submit an abstract to a conference as a means of getting to the conference, if I'm correct, Krish and James, Payal, you'll see that. So these are probably not the serious researchers, but those researchers who do generally are doing research and submitting it, I think it's the onus of the supervisor or the mentor to, to make sure that it doesn't stop at an abstract at the conference that they go through. I mean, in our situation, we are an academic institution. I find that people who are registered for a postgraduate degree, a postgraduate research degree, are also there's an incentive for them to present and get it published as well. So that's another a way of ensuring these abstracts really get published. But of course, not everybody's going to do that. And I think that's just another way. Yeah, that's my comment.
Payal? Unmute yourself.
Sorry, Krish, it's the volume dropped out for a second. Could you repeat the question?
And then I wanted to know what was your advice about converting abstracts to full publication?
Sorry, just I think my internet dropped out for a few seconds. Yeah, I think I completely agree. It's about the target that you make. So I think if you go back to step one, if you think about your project, you design it well. You design it with the aim to submit this as a paper one day, and what will the reviewers ask? What will the criticism be? You complete your project and you write a paper. The abstract is basically that first page of your paper, and that abstract is what you submit to a conference to have the opportunity to present your work in an oral format or as a poster. It's a summary of your work, and your full detail of the work is your paper. So I think that should be the aim to start with. You're aiming to convert your work into a full paper. I think some people can get discouraged by rejection, and I think that's the number one thing. Don't be discouraged. Keep trying. Learn from the comments from the reviewers. Try to modify your discussion, or if they've asked you to present your results in a different way or do further analysis, go back and answer all those questions. And then the journal may give you an opportunity to resubmit with the changes, or they may say, thank you, but no thanks, but here are some suggestions. And then so move on to another journal. Just don't stop trying. Like I said, every paper has a home. I learned that from Todd Barron. So he's published several hundred. So it's true. Your paper will get published one day.
I think that's a really very good take-home message. Every piece of work, every research project you have has a home. Finally, if you pursue that, and that will happen. I hope I have answered. We have answered the question that Nitin Jagtap asked. Thank you very much. Now this nicely leads us to the question about should trainees think about registering for a higher degree, like a PhD, or even the first step of it, like an MPhil, or maybe in some countries it's called the MD. So what are the views in the panelists about considering a higher degree? Let me start with you, Payal.
Yeah, I think it really depends on, I think the value of a higher degree is different depending on your institution or your country or your own personal reasons. I feel as an endoscopist, as an academic endoscopist, we achieve recognition from our publications, not from whether or not we have a PhD or an MD degree. I think that's just another, attachment to the end of your title, and for us, it doesn't really do much from a career perspective in your institution or academically, or from a promotion perspective. It's more about the publication rate and the number of students you supervise, etc. And that may be different in different countries and different places. So I think that's one of the driving forces. And again, I think, a higher degree is just another way of quantifying your research background. I often see, and I find this quite frustrating, I often see PhD students in maybe hepatology or IBD that do one randomized controlled trial that lasts for 3 years, and they come out with a PhD, and when you ask how many publications do you have, and it's often none, and maybe they've done one review paper, and maybe eventually they'll publish their study. And I think that's I don't think that's a great outcome, to have spent 3 years researching and you haven't produced any papers from your work, because you should be able to produce small studies, big studies, but you should be able to read and write papers in your 3 years of research that's represented your PhD. So I place higher value in someone who spent 2 years doing solid endoscopy and then published, a dozen, 20, 30 papers, versus someone who spent 3 years doing a PhD. I think when you bring that person into an academic forum, they have more to contribute in terms of discussion and talking about the data and the evidence for certain practices, versus someone who did a PhD in one topic.
I think that's a very valid point you made. So my take on this is that when people do a PhD or MD or whatever it is, it gives them a structured way of doing systematic review, literature search. So they get credits to do all these things, and that adds a bit of a value to the project, and also it gives an impetus to complete the project and get it published. And these days, I don't think anyone can get a PhD without 4 or 5 publications out of it, because those things are also looked into it. So that is really good value. So it depends on the institution you're working, and whether you're going to become a clinical academic or not. Then you would think about registering for a higher degree. And I agree, it depends on the personal circumstances and how much time one can put in to do this or so. And not everyone who is doing research in endoscopy needs to do a higher degree. But having said that, doing it, it helps you the other way around to try to encourage you to do research. So that's that thing. Yeah, good. Thank you very much for that, Payal. Coming from an academic institution, James, you're quite used to this. What is your take on that?
I think doing a higher degree, I have a doctoral degree, but that was really a thesis on a collection of papers that I did. So I did all these papers, and I put all these papers together to form a thesis. That's how so I think it's the research comes first, the degree comes second. So it didn't matter to me very much if I did not have the degree. So this is how I looked at it. What I found very useful was I did a diploma in biostatistics and epidemiology. The reason I wanted to do clinical trials, that I needed to learn all the terminologies, how to calculate sample size, how to do this chi-square test, life table analysis, and so on. So I needed to choose to do clinical research. So that's what I did. So a high degree is a knowledge and a skill that you acquire in order to do research. This is how I look at it. So the thesis actually came secondary, because people don't look at your thesis, people look at your papers that you publish. This is how I look at it. So the doctoral degree actually comes secondary. So
good. Thanks, James. I think that's very good experience that you shared. Sanjiv, you wanted to say something?
Yeah. I was going to say, if I could add to that, I completely agree. I mean, I think it's not so much about just getting the publications. I think a high degree, agree with you, it gives you that structure for your research. And I like what James said, which is quite important in our institution as well. There's a lot of training that comes with a higher degree, about especially things like statistics and study design, which as a clinician who's doing, you can use the word part-time research, sometimes our guidance is not so structured and clear. And for that reason, I would encourage someone to do a higher degree. But again, at the same time, I agree with Payal. It doesn't mean that the work you're going to come out with is going to be better than someone who doesn't have a higher degree. But I like the higher degree for the structure and the training. Yeah, that's all.
Thanks for that, Sanjiv. So we're almost running out of time. We have got about 2 or 3 minutes. So I think I'll start wrapping this up. So what we heard from the lecture was very basic tips and tricks of how you start and the fundamentals of doing research. And that was quite an excellent thing to start off. And I would like to really thank Payal for doing that. And from my point of view, I think research is everyone's business as such. Whoever is treating patients and seeing patients, I think research is everyone's business. The reason is because if our forefathers didn't do research or didn't find things or didn't innovate, today we would not be practicing endoscopy or medicine the way we are practicing. If 20, 30 years ago, the National Polyp Study, if they didn't do that, we would not be taking polyps out now. Because we showed that taking polyps out prevents colorectal cancer, we are doing it. Likewise, for example, if James didn't think about the randomized trial using omeprazole IV infusion for peptic bleeding, and we will not be using that in a regular basis. And it's almost a standard of care if a patient comes in with a GI bleed, a patient having intravenous PPI or double dose oral PPI. So it's very important to do these things because it adds to the literature, it adds to our clinical practice, and it directly transforms to how patients are being managed. So I think it's important that we all do it, but the more important thing is to do it in the right way. And as Payal showed, what are the different steps and what are the different ways of doing research is very important. And finding a mentor, starting small is always important. And I hope that this would have been useful for the people who have logged on, and this has been recorded so people can watch it later as well. Thank you very much for the panelists, Sanjiv Mahadeva, James Lau, and thank you again to Payal Saxena for this excellent presentation today. And I would like to sincerely thank all the people who have logged on to the webinar today. Thank you very much.